introduce myself. I know a lot of the people in this room, and but for those of you who I don't know, my name is Jerome Smith. I practice dentistry in Lafayette, Louisiana. I've been in private practice for 34 years. I just saw the other day, I got a notice that we're having our 35-year dental school class reunion. It's just hard to imagine that those years have gone by so fast. So some of my classmates are here, Gerard Karam, Jim Iverstein, Bill Donnelly's going to be here, Hunter Shormay, and some other friends in the audience as well. But I'd like to thank you for having me here today. I knew that today was going to be a problem. I got my car, a new car, and it says engine control fault. I don't even know what that means. So, you know, big red thing, so I just kept driving. And honestly, I don't even know where Harahan, I don't even know where I am. And I lived in New Orleans for 4 years. But anyway, nice looking crowd, definitely a nice facility. And is Darryl Borg here yet? Where's, God, I thought Darryl would be the first one here. I know, right? But I really want to thank Darryl and New Orleans Dental Association, particularly Joel with Megagen USA for having me here today. We're going to talk about some things that are observations from my practice. I want you to know I don't lecture for a living, and it's become real obvious throughout this course. In fact, when you look at your evaluation forms where it says, let me put my glasses on, where it says, was the speaker organized right now, you can go ahead and check off no. Was the subject matter well described on the pamphlet? You can put check no also. And would you have him come back and check off hell no for that one? Because I'm a clinical dentist, I have all the headaches and all the nightmares and then some that all of you have. And so I appreciate where all of you are coming from. I have my nephews working with me now. So it's nice to have an associate. I just started working 4 days a week about 8 months ago, and it's nice having him in there, but he's young, and he reminds me of how naive I was when I was that age, so I'm kind of having, we call him ready, fire, aim. You know, he just kind of takes off in these different directions, and it's hard to kind of hold back and let him make some mistakes and let him learn some things, but and it's painful to watch him endure some of the stuff we all have to, but I really admire the dentists that are out there doing what we do. You know, we all go into this to help people. The book Street Lawyer by John Grisham, they interview freshman law students, and they ask them, why did you go into law? And they all say, because I want to help people. Well, by the time they're seniors, if you ask them, why did you go into law, it's because I want to get out and make some money. And so we see in dentistry is we have a unique opportunity to help people, but we also have to run a business, and we also have to make a profit, and we also have to pay our people, we also have to pay our IRS and all those other things. So it's a high wire act. And for those of you that have more than one dental office like Jim Iverstein, I really do admire you, because you know, to me, just running one of them is really something else. We're going to talk a lot today about a lot of different things with some emphasis on this particular implant system. I will tell you this, Joel did not call me to buy the system. I called him to buy it because I was just so intrigued by it. And I'd worked with the rescue system for Megagen before. And this probably has revolutionized, for me, implant practice more than anything. You know, we've been placing implants for 28 years now. First case I did was in 1986 on my dental receptionist's husband. And we did 2 core vents. I did one on the right, and my partner, Dr. Barrios, did one on the left. Mine failed. His worked. And back then, I'm sure we were generating a lot of heat. We didn't have water pumps with coal saline and all these things we have now. So, you know, it's been neat to see how much things have evolved. At the same time, it's been interesting to see how much stuff we've acquired in terms of tools and bone grafting and this and that and this and that and all the instrumentation that we need to run a practice that's focused on implant dentistry. So anyway, happy to be here. I'm going to, and also Joel, remind me, because I really want you to come up and explain some of the features to the system when we get to that part. You may have to adjust that projector a little bit. You see how this is cut off? So I was a LSU graduate in 1980, best class in the history of the dental school, without question. As I said before, we've been doing implants since 1986. A lot of what I've lectured on is nuts, bolts, and nightmares, because what you see in the journals and what you see in practice after you've been out for a while are not quite the same. There should be a dental journal that only allows you to put in the before and then the after 10 years later, not like the day you put the case in, but that's all we see. Dennis Tarnow, and I'll show this in a minute, you know, what I see, and I'm sure what Ed Savoy sees, and Dr. Nasser and people that are out there is there's this new growing disease called peri-implantitis that I think is going to give the periodontists a lot to do for the next, until you retire. And Dennis Tarnow is saying that approximately 30% of the cases out there have some degree of peri-implantitis, and we see it in our practices. These patients, a lot of these patients just are not doing what they're supposed to do at home. They're more prone to the disease. I got a guy who keeps a cigar in his mouth all day long. I'll show his case in a little while. We're doing it for about the third or fourth time. We work with about 100 referral offices, so we have a lot of, we have an opportunity to treat a lot of people, and so a lot of what we're going to talk about today is just based on, doing this for 28 years and so forth. And I'll address some of the controversies and some of the sacred cows in implant dentistry as well. This is my dental school class. This is Dr. Odom on the right. That's Dr. Mancotti on the left, one of our instructors in the periodontal department. This is our band, the Matrix Band, back when we were seniors. This is me learning how to use nitrous oxide with two of my buddies. But we had great times, and it always, when I come back to New Orleans, it reminds me of all the good times that we had way back when. Talking about implant dentistry, we spend a lot of time in the practice trying to educate people because they don't know anything. It's like when your guy's fixing your computer and he said, "Oh, we found the problems in the motherboard," and blah, 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 and you're looking at him, you don't know what he's talking about, but you're nodding your head and you're staring into the sun. You don't know what he's talking about. And I find that our patients really don't understand any of this stuff. So we try and show them the features of all this stuff, because when they come in, all they want to know is how much is it going to cost. And I won't answer them. It's like you've really got to understand what this is all about, what the benefits are, what the risks are, and then you decide if this is a priority. An automobile is, because everybody's got one of those, and the average price of a car in the United States is $25,000, and everybody's got one. And something as important as oral health, I just find that people just don't know what's going on. And when they're properly informed about all of these things that dental implants will do for them, you can start to see the light bulbs start to go off sometimes. And so a lot of what I'm going to talk about today has to do with case acceptance, because, it's one thing if you've got the best specialists in the world in New Orleans and you've got the best clinical dentists in the world in New Orleans, and you have patients that don't accept treatment and you blame it on the economy. I got news for you. There's a lot of people out there that will use discretionary income to get this done if they understand what it's all about and what it can do for them. And and I firmly believe that. So we have a website with a bunch of before and afters on different types of cases. These are some of the people that we have to be a little bit wary about. We do implants on patients that smoke. Sometimes I think I ought to have my head examined, because those are the ones that come back to haunt us sometimes. Not all of them. In people with bad oral habits and poor oral hygiene, and patients that are completely psychotic. We have a lot of those in our office. I'm sure you all don't, but we do. But really getting through all this stuff and looking at all the attenuating factors that are involved in implant dentistry, there's a lot to look at. I moved about 4 years ago. Something I never thought I'd do at age 55 would be to build a dental office. But I needed a bigger place because I wanted to take in an associate, and we needed more room and all this kind of stuff. But what I want you to understand is I do not have this highfalutin practice. This is like the second day in the new building. This is one of my patients. This is a nice vehicle with his dog tied up, and his dog shitting all over our driveway. So this is not a highfalutin practice in Lafayette, Louisiana. It's very similar. My patients are similar to your patients. It's just that we've spent an inordinate amount of time trying to develop an environment where people understand what's going on. They see these, we have a caring staff and all these kind of things, and it's just everything. The recipe is almost perfect. It never is, but it's getting close. The thing about implant dentistry is there's so many things that you have to look at in order to put this piece together. And one day when we were putting together this implant continuum at LSU, we started looking at all the different factors that we need to cover during the course of the continuum. And the truth of the matter is, it's impossible. And even though I've been doing this 28 years and I read about it all the time and I do it every single day, I'm still really intimidated by what I don't know. And when I get around a guy like Carl Misch or Ed Savoy or somebody like that, there's just so much information out there that it's pretty difficult to master. And that's just maybe the surgical end of it. The prosthetic end of it, a lot of times can be just as daunting. So one of the things that I really want to talk about today is the restorative aspect of treatment, and how can we simplify that. And an example of that is using custom abutments. And so today, I have a whole menu of things that we can go through. If the people in the audience have any preferences, like, man, I wish you'd really talk about zest attachments. I wish you'd talk about locator, that is zest, locator attachments, or what about custom abutments in the anterior with zirconium, things like that. At the lunch break, if there's anything that you really want to cover, just come up and mention it to me. The thing I wanted to mention that I've gotten a lot out of is this is Dental XP. It's an online. How many people subscribe to this? All you guys? I tell you, it really is a nice resource. To be able to listen to lectures like Dennis Tarnow and people like that, Salama, Garber, all these guys, really, really well done. Kind of keeps you updated on everything, and you don't have to leave your house. So if you hadn't looked into this, it's $350 a year. It's a bargain. It really is a bargain. So today's topics, we're going to try and look at presenting implant treatment effectively, simplifying implant treatment. We'll talk about CT scans. We have a Prexion. I don't know if it's any better or any worse than any other machine, but I like it and I'm used to using it, and we use it every day. I think we've had it 4 years. We've taken 2,900 scans with it. How much do you charge? Sometimes $45, sometimes $150. It just depends on what we're doing it for. Sometimes, Tammy will take a scan on somebody with a mandible that wide, and they need tooth number 19 replaced. We don't need a scan for that. On the other hand, the longer that I use this thing, the more I'm amazed at the amount of endo problems that we're finding, and the amount of bone problems that we're finding that prior to having this technology just didn't know they were there, including my own CT, which I'll show you in a little while. We'll also talk about bone grafting. We believe in socket preservation. I know it's controversial, but I really have done it for a long time. I think it works real well. I'll talk about what we use for socket preservation. We'll talk about concomitant grafting with placement, sinus grafting, both lateral and crestal approaches, and then augmentation for future site placement using the sonic well system, as well as aesthetics and occlusal management. This right here, I'm afraid, gets kicked to the back of the bus sometimes. And since I've been doing this so long, I've seen cases, one as recently as a month ago, where the implant's been in function in the tooth number 3 position for 18 years, and all of a sudden it loses integration. And, and you start thinking, this wouldn't have happened if we'd have managed the occlusion better, because things change with time. And, an implant's supposed to barely touch an opposing tooth, and all of a sudden there's some changes in the joint. Now the implant's getting pounded by a lower molar, and it's up in the maxilla, and now we've got a loose implant back there. We'll also talk about working with specialists and what your responsibility is, contraindications and liability. We'll talk, like I said, a lot about custom abutments and platform switching. You can't talk about implants without addressing soft tissue management. Charges and insurance coding I won't go into. Managing patient expectations I will go into. And managing complications, because this is a big part of the deal. I keep telling my nephew, I said, I don't think I had any failures for the first 5 years. Maybe a few, but not that many. And then after you've been out 10 years, then these things start coming back. There's a broken abutment, or the crown is starting to spin. And managing all those things can really become a headache. Unfortunately, I've been doing this so long that when people move into town and they have an implant problem, they always send them to me. And so I'm always trying to figure out what kind of implant this is, and there's a broken screw, and where can we find the parts and all that. And it really is undaunting. There was a time where there were 250 companies that sold dental implants. Now it's probably 5 times that. And then we have people that go across the border and have them done in Mexico. And then when they have a problem, they come to our office. It's like, I have no idea what kind of implant that is. And we have boxes, we have cabinets full of screws and tools and all this, and some of this stuff I've never seen before. We'll talk about enhancing wound healing using platelet-rich fibrin, infection control, auxiliary training, and what implant to use. And like I said, I'm leaning way toward using the AnyRidge system for reasons that we'll look at and talk about today. But basically, if you think of, and I'm going to use maxillary bone as an example, if you think of maxillary bone as like sheetrock or a little denser than balsa wood or something like that, you don't put a machine screw in there, And maybe that's an oversimplification, but that's what I've seen in using implants with deep threads that cut into the bone, that grab a lot of bone, and that maintain a lot of bone to implant surface contact area. And so that's kind of what this implant's a lot about. It enables us to really start doing much more in terms of immediate placement. The other thing is, what we have to look out for is there's a lot of stuff going on out there. You know, this is growing by leaps and bounds. I mean, Ed's been doing implants for a long time, so have I. We used to do a couple a month, and now it's like all we do. You know, it's like the public's demanding it. Dentists are realizing that a 3-unit bridge is not state-of-the-art dentistry anymore. I mean, to grind down, you know, tooth number 30 and number 28 to replace 29 is not the best that we can do nowadays. And so we see some of this stuff going on. Straumann just invested $30 million? Well, why? What for? For the coating? That's a lot of money. So Straumann invests in Megagen, which is Joel's company, which we're going to be talking a lot about today, $30 million. Cybron bought into Implant Direct. And then look, Nova Biocare, Danaher just bought them for $2.2 billion. So there's a lot going on. Zimmer just bought Biomet for $13.4 billion. So there's a lot going on in the implant industry. A lot of it's driven by money. You know, as a clinical dentist, I'd like to kind of try and decipher through some of that stuff and just kind of talk about, you know, what's really working well for us. This is the thing that I'm into. You know, if we can take somebody like this, where this tooth is going south, but this tooth back here is still good, and we do, I swear to you, we must do this almost every day. It's just so common where somebody's got a 3-unit bridge and or 4-unit bridge in this case, and one of the abutments is history. You know, and if it's an endo tooth, the chances of it becoming a problem later on are great, and that's what's exactly happened here. And so a lot of times we will do a crestal approach, sinus lift, put in a large diameter AnyRidge implant, and I mean you can be going into 3 millimeters of bone with this particular implant. And when you're putting it in, it's like, man, I can't believe how much torque it's taking to put that thing in there. And so, you know, osseointegration is important, and that's where we're all headed. But initial fixation is a big deal. And so if we have an implant that will give us good initial fixation in the maxilla, then this will allow us to be able to not have to graft this and then come back 6 months later, put the implant in. We'll put the implant in now, you know, section the bridge, take the eye tooth out, take this canine out, do an immediate placement with this implant. When this thing goes in, these flutes really engage the cortical as well as the cancellous bone very well. And so sometimes you're using 50, 60 Newton centimeters of torque to get these in. And we'll talk about immediate provisionalization because this patient's going to leave with a canine. And I'm not going to make an Essex appliance, and I'm not going to make a flipper because I wouldn't want to wear one for an afternoon. I'm not saying I never do, but it's not very often that we do because we get such good fixation with this that we can put provisionals on immediately and then shape the provisional to create emergence in the soft tissue to where when the final restoration goes in one of these days, it looks like a real tooth. So as an overview, we use Blue Sky Bio, internal Zimmer hexed clone in the office, not very much anymore, but it was kind of my go-to implant for a while. My partner uses BioHorizons because he thinks that the laser lock is the key to implant dentistry. He thinks it's the most important thing out there because you've got these laser grooves and the connective tissue apparently attaches to these grooves. And as Dennis Tarnow said, let's wait 10 years and see if that really was a good idea or not. You know, so what I like about these is they do make a 3.0 millimeter diameter implant for those tight spaces, maxillary lateral incisors, and then you can have a custom zirconium abutment so that you can make 2 all ceramic crowns that look like real teeth in the front, and that's quite an evolution from what we were doing even 10 years ago. Megagen also has a 3.0 millimeter implant, which came out how long ago? It's recent. Okay. We have some, but I haven't done any yet. And I'm going to talk a lot about the AnyRidge system. I think that probably 85 to 90% of the implants that I do now are this system. I'm going to mention is Spree Dental Lab in Golden, Colorado, and Midwest Dental Ceramics, which is in Iowa. These are 2 labs that we use to make custom abutments, and I'm telling you, when we got out of doing stock abutments and went to custom abutments, there's no way to go back. There's no way to go back. And I'll show you some examples. I've seen in the literature that it says one of the #1 causes of implant failures is cement getting shoved under the gum line. And I've seen it, and I know Ed Savoy's seen it. And we are using the custom abutments because we can determine, we can tell the lab we want a 0.5 millimeter subgingival margin on the facial of 8, and I want 0 on the mesial and distal, and I want a 1 millimeter margin on the lingual for a central. In the back, everything is either 1 millimeter supergingival or it's right at the free gingival margin. So then it's just about impossible to trap cement down there. But the other day I had a real nice case I did. Chuck Bernard, one of my best friends, restored tooth number 19. The x-ray looked perfect. But man, he kept having some oozing and some pus, and I opened it up. Before I opened it up, though, I accessed the coping screw through the crown because I wanted to get the crown off. It's so much easier to do periodontal regeneration around an implant without the crown and the abutment in the way. So I unscrewed it. As soon as I unscrewed it, there's a huge piece of cement right on the mesial of this stock abutment with a crown attached to it. And I wrote in my dictation to him, I said, this is why we're not using stock abutments anymore, because you know, the mesial margin of this stock abutment, because it's 360 degrees, you know, the margins are not following the free gingival margin. It's just a circle. And so the mesial margin was subgingival. And if you take a crown and you load it up with cement, you get hydraulic force, and that cement will take off. You know, I've seen some pictures of it on implant threads. I mean, it can really cause a mess. So, I'll show some examples of this. And in fact, this lecture has no direction at all. It's just a bunch of stuff on a screen, and I'm just going to pick some things out to speak on that, you know, when the Spirit inspires me. And probably one of the first things I want to talk about today is custom abutments, because most of the people in the audience are restorative people. I think that's going to mean more to you than a lot of the other stuff. I'm going to talk about the Trios 3-shape scanner. How many people in the room have scanners like Serac or iTero and all that? You know, just a few. Honestly, this thing right here, not real big on it. My associate was real big on it. He wanted to get it. We got it. It has not been the greatest thing since sliced bread for me. So translation is, if you hadn't bought one yet, don't go running out to spend $40,000. And then after you spend that money, there is a monthly support fee that I just found out about the other day. It's like $400 a month after the first year. And it's like, man, that was a lot of commotion when I can go in the room and put an impression transfer in and put an impression in and leave. And it goes in a box and it goes to the lab and it comes and we get back a perfect abutment, anatomically perfect abutment, and a temporary that looks as good as the final crown. And so that's what the patient goes back to their referral dentist with. Or if I'm going to make the final crown, I can just take an impression right there, no cord, no nothing, and put my temporary back in, and we're good to go. So it's a bunch of things. It's becoming more efficient for me. It's producing a better end result, and it is also helping to avoid cement entrapment during the cementation phase. We'll talk about the Prexion machine, not necessarily this machine, but just CBCT in general. You know, fortunately, the prices have come down. Back in about 10 years ago, 9 of us got together and bought an iCat. It was $200,000. We opened up an imaging center, which wasn't far from my office, so we could just send the patient over there. They do the CAT scan, and then the next day they'd bring the CD to the office, and we could evaluate the scan. And we lost our ass on that deal because we thought it was going to be a good business, and it wasn't a good business. But it did allow us to have a CT machine for 8 years and get scans done. And then you get to the point where you say, well, now the scanner is half the price, and the quality is much better. So that's why I wound up buying the Prexion. It's just so much better to have it right there in the office. After the scan is done, you can show the patient their bone. You can pick implants out, put them on the screen, and so on. We use digital radiography and digital photography like a lot of you do. We use patient education, cases, and videos. All are on a website that I'll tell you about later because you can use it. It's a website we put together with all of our stuff on it because we can't find anything. You know, it's like, oh, you have a case just like, I can't remember the guy's name. I wish I could remember his name so I could show you his case. Well, finally, somebody got the idea of, let's put all this up on a website so we know where it is, and then we'll become familiar with our catalog of what we've got. And so basically, just about every type of case that we do is on this website, and I'll show you the link to it later, because feel free to use it in your office. And we do formal case presentation with cases that are worked up in using Picasa, which is a Google product, or Photoshop and PowerPoint. Because I want people to be able to see, hey, look, this is a condition of your mouth. And a lot of times when they look at these slides, are you still doing that, Jimmy? You're still routinely? Yeah. Yeah. We just developed a routine where if it's going to be an involved case, I want to take photographs and CT scans, some x-rays, and kind of get to know the patient and all that. They got to come back for a consult. I want to take some time to sit down and think it through and then put it together in PowerPoint and kind of, like Abraham Lincoln said, if you have 9 hours to cut a tree down, you need to spend about 8 hours sharpening your axe. And so I like to spend the time with the photographs and x-rays and CT and put all this stuff together in a folder, and then when the patient comes back in, Tammy sits down and shows them all the stuff. And what I found out was when Tammy presented the cases, the case acceptance was a lot higher than when I did, because I would have a tendency to go off on a tangent and start talking about coatings and titanium and all these kind of things. They're not interested in all that. And Tammy doesn't have a vested interest in whether or not they accept the case, and I do, so I guess it works out better that way. Some people call that a treatment coordinator. She does a good job. She's been doing that for me for a long time. And we'll also talk about socket grafting. We use 50/50 cortical cancellous bone. I get mine from the MIS company. They're the best prices that I've ever seen over everybody else. We use fusion bone binder, which is a compound that my cousin and I developed, which is no longer available in Louisiana because of the debacle that occurred with the New England compounding pharmacy. Y'all saw the news, and they talked about steroids got contaminated with fungus. They've had, 35 deaths throughout the United States from this. And so the FDA has really come down on the compounding pharmacies. So my cousin has elected to get out of making this. But I did find a compounding pharmacy in Texas that we can order from, and we'll talk a lot more about it. All it is a compound that enables you to mix it with freeze-dried bone to create a putty. So when you put it into place in the socket or on the side of a ridge or wherever, it stays there. When you start getting some bleeding, you don't see all the particles leaking out. Because for a long time, we'd do a socket preservation, the patient would come back in, and a week later or 10 days later, we're looking at a dry hole. So we'll talk about that as well.